Fever is one of the most common complaints in children. Now, fever of unknown origin, or FUO, is defined as a temperature higher than 101 degrees Fahrenheit, or 38.3 degrees Celsius, that lasts for at least 8 days and has no underlying cause in spite of a formal evaluation. Okay, so causes of FUO can be divided into two large categories: infectious and non infectious. Infectious causes include generalized infections, especially bacterial ones, like brucellosis, cat scratch disease caused by Bartonella hensleyi infection, Lyme disease caused by Borrelia infection, mycobacterial infections such as tuberculosis, salmonellosis causing typhoid fever, typhus caused by rickettsial infections, tularemia caused by Francisella tularensis, psittacosis caused by Chlamydia phyllositosae, Pasteurella, along with various other infections from Campylobacter, Yersinia legionella infections, Vibrio parahemolyticus, or vulnificus. Likewise, there are viral infections, including adenovirus, influenza, CMV, EBV, arboviruses, and HIV. There are parasitic infections like malaria, toxoplasmosis, and babesiosis. And there are fungal infections like blastomycosis, cryptosporidiosis, histoplasmosis, and coccidioidomycosis. But there are also localized infections like pneumonia, bone and joint infections such as osteomyelitis and septic arthritis, infective endocarditis, meningitis or encephalitis, intra-abdominal abscesses, hepatitis, upper respiratory tract infections such as mastoiditis and sinusitis, dental infections, and urinary tract infections such as pyelonephritis. Non-infectious causes include inflammatory conditions like Kawasaki disease, autoimmune conditions like juvenile idiopathic arthritis, rheumatoid arthritis, polyarteritis nodosa, and systemic lupus erythematosus, neoplasms like leukemia and lymphoma, inflammatory bowel disease, immunodeficiencies, familial dysautonomia, and periodic fever syndromes like familial Mediterranean fever, cyclic neutropenia, and periodic fever with aphthous stomatitis, pharyngitis, and adenitis syndrome, or PFAPA. FUO can also be induced by medications, including antimicrobial agents like acyclovir, carbapenems, cephalosporins, and tetracyclines, anticonvulsants like barbiturates, carbamazepine, and phenytoin, antidepressants like doxepin, anti-neoplastic agents like interferons, 6-mercaptopurine, and bleomycin, cardiovascular drugs like clofibrate, furosemide, and heparin, histamine 2 blockers like cimetidine, immunosuppressants like azathioprine, and NSAIDs like ibuprofen and salicylates. And those fevers typically resolve within a few days of stopping the medication. Another case of FUO is neurologic injury that causes the hypothalamus to dysregulate a child's temperature. Finally, some portion of FUO cases remain undiagnosed and often resolve spontaneously. Managing FUO begins with asking the family to keep a fever diary that records the date and time of fevers, the height of fevers, associated symptoms, and any medications that were given. Sustained or continuous fevers generally persist throughout the day with less than 1 degree Celsius of variation. They are usually seen with typhoid fever or typhus. Fevers that fluctuate more than 1 degree Celsius throughout the day are called intermittent and remittent fevers, where intermittent fevers descend back to normal temperature, while remittent fevers always persist above normal. Intermittent fevers typically suggest a pyogenic bacterial infection, like an abscess, but may also be seen with juvenile idiopathic arthritis, whereas remittent fevers are associated with viral infections, but may be seen with some bacterial infections like infective endocarditis. If the child remains afebrile for more than 24 hours between febrile episodes, the fever pattern is called relapsing or recurrent. In relapsing fevers, the afebrile periods last for several days and suggest malaria, Borrelia infection, or lymphoma. In recurrent fevers, there are afebrile periods of more than 7 days, seen with periodic fever syndromes, cyclic neutropenia, and immunodeficiency states. Next, it's important to identify additional complaints. Moving from head to toe, there could be a history of conjunctivitis with limbus sparing, which means red eyes with a white margin right around the iris in Kawasaki disease, in which case there will also be a rash, which starts out polymorphous, but later desquamates, or flakes off. Adenopathy, or enlarged lymph nodes, especially concerning the cervical lymph nodes. A strawberry tongue, which is when the top layer of cells on the tongue sloughs off, giving the tongue a very red, strawberry-like appearance. Their hands and feet might develop a rash and swell. And finally, 5 or more days of high fever that doesn't resolve with antipyretics. Just remember that these Kawasaki patients CRASH, crash, and burn. We should also ask for nasal discharge in case of sinusitis or epistaxis in case of leukemia, oropharyngeal symptoms like pharyngeal hyperemia in case of CMV or EBV infection, recurrent pharyngitis with ulcerations in case of PFAPA syndrome, and dental abscesses related to sinusitis. There might also be lymphadenopathy in case of infectious mononucleosis, cat scratch disease, tuberculosis, or lymphoma, respiratory symptoms like cough in case of bronchitis or pneumonia, gastrointestinal complaints like abdominal pain or loose stools in case of salmonellosis, an intra-abdominal abscess or inflammatory bowel disease, genitourinary symptoms like flank pain, dysuria, and frequent urination in case of genitourinary tuberculosis or brucellosis, and musculoskeletal symptoms like limb or bone pain in case of leukemia or osteomyelitis. Another important thing to ask for is specific exposures. These include contact with animals, like birds for Chlamydia psittaci, Cryptosporidium, and Histoplasma capsulatum, household cats or kittens for Bartonella hensleyi and Toxoplasma gondii, dogs for Brucella and Pasteurella, farm animals like cows, sheep, and goats in case of Brucella, and fish, water mammals, oysters, or clams for Vibrio parahemolyticus, Vibrio vulnificus, Legionella, and some Mycobacterium species. There are also associations with more exotic animals, like ferrets for Salmonella, Campylobacter, Cryptosporidium, and Leptospira, squirrels for Toxoplasma and Rickettsia, horses for Salmonella, Campylobacter, Cryptosporidium, and Brucella, rabbits for Salmonella, Francisella tularensis, Yersinia, Pasteurella, and Babesia, rodents for Francisella tularensis and Leptospira, and reptiles like turtles in case of Salmonella. Recent travel to endemic places can also be a clue for malaria, tuberculosis, Lyme disease, as well as fungal diseases like histoplasmosis, blastomycosis, and coccidioidomycosis. Tick bites are also risk factors for tularemia, Lyme disease, rickettsia, and babesiosis, while mosquito bites are risk factors for arbovirus infections and malaria. There's also often history of consumption of raw meat and unpasteurized milk in case of brucellosis, or raw shellfish or unwashed vegetables in case of toxoplasmosis. A history of pica, like eating dirt, might also be seen in cases of toxoplasmosis. And then, medical treatments may raise suspicion of drug fever in case of medication consumption or intra-abdominal abscess, especially if there's a history of abdominal surgery. Finally, several conditions are more common regionally. For example, familial Mediterranean fever in those of Sephardic Jewish, Armenian, Turkish, and Arab descent, and familial dysautonomia in those of Ashkenazi Jewish descent. Next is the physical examination. Normally, for every 1 degree Celsius of fever, we expect the pulse to increase by 8 beats per minute. This is known as Liebermeister's rule. So, for example, if the temperature increases from 37.4 to 38.4 degrees Celsius, then we'd expect the heart rate to rise from 120 beats per minute to 128 beats per minute. When this doesn't happen, it's called relative bradycardia or Fagett sign. And it's most often associated with typhoid fever or legionellosis. Evidence of a growth delay or short stature may occur in chronic conditions like inflammatory bowel disease. Next, the skin should be examined for rashes such as petechiae in infective endocarditis, papular lesions in cat scratch disease, an eschar in tularemia, erythema migrans in Lyme disease, a macular salmon pink rash in juvenile idiopathic arthritis, and palpable purpuric lesions in polyarteritis nodosa. We should also look for edema and hyperemia in the pharynx, which could be a sign of infectious mononucleosis caused by Epstein-Barr virus, or cytomegalovirus, toxoplasmosis, tularemia, or leptospirosis. By examining the eye, we might notice conjunctivitis in Kawasaki disease or absence of tears and corneal reflexes in familial dysautonomia. A cardiac murmur could indicate endocarditis, and, in that situation, the mouth should be inspected and palpated for dental infections. The sinuses should also be palpated for tenderness, pointing to sinusitis. Bone or joint tenderness may indicate osteomyelitis or septic arthritis. Lymph nodes may also be enlarged and tender in cat scratch disease or Epstein-Barr infection, or enlarged but painless in case of lymphoma. Liver and spleen enlargement commonly occurs in salmonellosis, brucellosis, or malaria. Okay, now we're ready to order diagnostic testing. First, all children with a fever of unknown origin should get a CBC and a peripheral smear, ESR and CRP, blood cultures, urinalysis, and urine culture, chest x-ray, PPD skin testing, or interferon gamma release assay, electrolytes, BUN, creatinine, AST, ALT, and HIV serology. Additional tests for infectious causes might include serologic or molecular tests for EBV, CMV, brucella, or tularemia. In addition, there might be a need for sputum cultures if there are any signs of a respiratory infection, stool studies for if there are signs of a gastrointestinal infection, and finally, lumbar puncture and CSF studies if there are signs of meningitis. For neoplasms, we can check the uric acid, lactate dehydrogenase, and ferritin levels, and later proceed to bone marrow biopsies for leukemia. For rheumatologic diseases, we can order serum anti-nuclear antibodies, or ANAs, and complement levels like C3, C4, and CH50 for systemic lupus erythematosus, and rheumatoid factor for rheumatoid arthritis. Finally, for immunodeficiencies, serum immunoglobulin concentrations, lymphocyte markers, and antibody titers to past vaccinations should be sent. Imaging tests may also be indicated, including a sinus X-ray to look for sinusitis, abdominal imaging like ultrasound, CT or MRI for intra-abdominal abscess or tumors, or deep infections, bone scans for osteomyelitis, echocardiogram for infective endocarditis, and PET scan to look for tumors all over the body. In general, empirical treatment with anti-inflammatory medications or antibiotics should be avoided in children with fever of unknown origin, especially antibiotics, because they can mask the symptoms of serious infections and also make it difficult to isolate an organism from the blood or any other site through cultures. Exceptions are nonsteroidal anti-inflammatory agents in children with suspected juvenile idiopathic arthritis and anti-tuberculosis antibiotics in severely ill children with possible disseminated tuberculosis. Alright, as a quick recap. Fever of unknown origin is diagnosed in children with fever of at least 8 days duration in whom no diagnosis has been found after initial evaluation either in the hospital or as an outpatient. The most common cause is infection, followed by connective tissue disorders and neoplasms. However, it is not uncommon to never come to a definitive diagnosis. Diagnostic approach includes history to determine the fever pattern, associated complaints, exposures, and ethnic background, as well as physical examination, including general assessment of vital signs and growth, skin, eyes, sinuses, oropharynx, lymph nodes, liver, spleen, and limbs. Diagnostic tests recommended for all children with fever of unknown origin include CBC and peripheral smear, ESR and CRP, blood cultures, urinalysis and urine culture, chest radiograph, tuberculin skin testing, serum electrolytes, BUN, creatinine, and liver enzymes and HIV serology. Additional lab and imaging tests might also be ordered depending on the history, examination, and initial tests' findings. Empiric treatment with anti inflammatory medications or antibiotics is generally not recommended.